Guideline for the Investigation and Management of Red Cell Antibodies in Pregnancy. A British Society for Haematology Guideline. Recommendations for consent, request forms and samples. It is essential that request forms are accurately completed and samples from pregnant women are correctly identified. Misidentification at the time of sampling could lead to an incorrect blood group being assigned to the transfusion record. This could result in errors in anti-D immunoglobulin prophylaxis, missed or inappropriate administration of prophylactic anti-D, and errors in the selection of blood components. Recommendation. Samples should be dated, labeled and signed by the person taking them, in the presence of the pregnant woman who should, whenever possible, be asked to state their full name and date of birth. Sample labels pre-printed away from the phlebotomy procedure or taken from the notes, for example. Addressograph labels should not be used. Grade 1C. Laboratory tests. ABO-D typing. Screening for red cell antibodies. Antibody identification. Measurement of antibody concentration. Wherever possible, testing should be performed on automated equipment that ensures positive sample identification, with electronic transfer of results to the Laboratory Information Management System, LIMS. Recommendation. ABO and D grouping should be performed in accordance with the guidelines for compatibility procedures in blood transfusion laboratories, Grade 1C. If clear-cut positive results are not obtained in D typing, the woman should be classified as D negative until the D status is confirmed, Grade 1C. All pregnant women confirmed to be D negative should be given written information about their D negative status and the importance of anti-D Ig prophylaxis if the fetus is predicted to be D positive by cell-free fetal DNA, cfF-DNA, or if the fetal D type is unknown. Their D status should be clearly recorded in the notes to inform those responsible for their care of the need to offer prophylactic anti-D Ig, Grade 1C. The screening cells and methods used for red cell antibody screening should comply with the guidelines for compatibility procedures in blood transfusion laboratories, Grade 1A. The procedures used for identification and exclusion of red cell antibodies should comply with the guidelines for compatibility procedures in blood transfusion laboratories, Grade 1A. The concentration of each antibody capable of causing HDFN should be assessed independently. For specificities where there is a national standard preparation, quantification should be undertaken. Other antibody specificities should be measured using titration, Grade 1C. Antibody quantification and titration. Antibody quantification requires specific equipment and measures antibody concentration against a national standard, National Institute for Biological Standards and Control, NIBSC. Anti-D and anti-C are the only antibodies that are currently quantified, and they are reported as IU/ml. Antibody titration is used to assess the concentration of clinically significant red cell antibodies other than anti-D and anti-C. Recommendation. If potentially clinically significant maternal antibodies have been identified, paternal testing, including whether heterozygous or homozygous, should be considered to predict the risk to current and future pregnancies. This may be particularly relevant if non-invasive fetal genotyping is not available for the corresponding red cell antigen, Grade 1B. Fetal genotyping. It is possible to determine fetal RHD, RHCE, and KEL*01 genotypes using cfF-DNA from maternal blood samples, thereby avoiding the need for invasive fetal blood sampling. Fetal genotyping is useful both in predicting HDFN in individual cases where clinically significant red cell antibodies are present, and as mass screening to guide anti-D Ig prophylaxis for D-negative women with no immune anti-D. Recommendation. Non-invasive fetal blood grouping using cell-free fetal DNA, cfF-DNA, from maternal plasma in allo-immunized pregnancies can be performed for RHD, D, RHCE, C and/or E, or KEL*01, K, with a false negative rate of less than 1%. These tests should be requested at the gestation advised by the reference laboratory used, by obstetricians or fetal medicine specialists who can explain the implications of the test findings having undertaken testing at the appropriate gestation, Grade 1C. It is important that samples are not sent too early in allo-immunized pregnancy as the levels of cfF-DNA rise with gestation. False negative results of CFF DNA typing have been reported for KEL*01, K, at 17 weeks gestation. The false negative rate for RHCE, 4C, and RHD, 4D, genotyping performed at or after 16 weeks gestation is less than 1% with the reference laboratory in England. Samples for fetal K genotyping should not be taken before 20 weeks gestation. Recommendation: fetal RHD typing using a high-throughput methodology in pregnant women who have not formed anti-D, as part of a screening program to target anti-D Ig prophylaxis, is sufficiently accurate for implementation from 11 weeks gestation. The cost-effectiveness of such testing is dependent on provision at a point in the antenatal care pathway that does not necessitate an additional visit. Grade 1C. Antenatal testing protocols. Routine antenatal testing. Recommendation: all pregnant women should be ABO and D typed and screened for the presence of red cell antibodies early in pregnancy, at booking, and at 28 weeks gestation. In D-negative women, the 28-week sample should be taken before the administration of RAADP, grade 1B. In pregnant women with no clinically significant red cell antibodies capable of causing HDFN present at 28 weeks gestation, no further routine antenatal blood grouping or antibody screening is necessary, grade 1B. Red cell antibodies detected in pregnancy. Recommendation: all pregnant women who have previously had a baby affected by HDFN should be referred as early as possible ahead of 20 weeks gestation to a fetal medicine specialist for assessment and advice, irrespective of antibody concentration or specificity, grade 1B. The concentration of passive anti-D Ig in maternal samples post-prophylaxis rarely exceeds 0.4 IU/ml unless anti-D Ig exceeding 1500 IU has been administered. The peak concentration of anti-D Ig detected after 1500 IU of intravenous anti-D Ig in a pharmacokinetic study in pregnant women was equivalent to 0.4 IU/ml and following intramuscular anti-D Ig 0.2 IU/ml. Procedures to follow where anti-D is detected in pregnancy. Determine whether anti-D Ig has been administered, not just issued, and its clinical indication, that is, whether as RADP or following a potentially sensitizing event, by asking the woman and seeking written confirmation in the notes. Undertake quantification, unless immediately prior to delivery, in which case the baby should be monitored for signs of HDFN. If any of the following apply, then the antibody should be monitored as for immunized women, that is, at 4 weekly intervals to 28 weeks gestation, and at 2 weekly intervals after 28 weeks, until delivery, or until serial monitoring by fetal middle cerebral artery, MCA, peak systolic velocity Doppler has been instituted and serial testing deemed unnecessary, or anti-D is no longer detectable. Anti-D was detected at or before the 28-week gestation RADP administration, even if anti-D Ig was administered earlier in pregnancy, as the risk of falsely labeling immune anti-D as passive anti-D Ig when detected at or prior to 28 weeks gestation is significant. There is no definite record of prior anti-D Ig administration. Anti-D was present before the first administration of anti-D Ig at any gestation. The level of anti-D is greater than 0.2 IU/ml. If the anti-D level is less than or equal to 0.4 IU/ml after up to 1500 IU of anti-D Ig have been administered, then prophylactic anti-D Ig should continue to be offered for routine prophylaxis and potentially sensitizing events in accordance with the BSH guideline for the use of anti-D Ig to prevent HDFN unless it is established beyond doubt that the anti-D is immune, in which case anti-D Ig prophylaxis is no longer indicated. If doses more than 1500 IU anti-D Ig have been administered, then a level of greater than 0.4 IU/ml may be achieved because of passive anti-D Ig. Therefore, prophylactic anti-D Ig should continue to be offered for routine prophylaxis and potentially sensitizing events in accordance with the BSH guideline for the use of anti-D Ig to prevent HDFN unless it is established beyond doubt that the anti-D is immune, in which case anti-D Ig prophylaxis is no longer indicated. After 28 weeks gestation, where all the following apply, testing should continue as for non-sensitized women, that is, there is no requirement for further antibody testing after 28 weeks gestation. and anti-DIG prophylaxis should continue to be offered in accordance with the BSH guideline for the use of anti-DIG to prevent HDFN. Anti-D was not detectable in a sample taken immediately prior to RADP administration. The timing of RADP should be at 28 weeks gestation but will sometimes be slightly earlier or later. There is a written record of administration of anti-DIG in the preceding 8 weeks. The concentration of anti-D is less than or equal to 0.2 IU/ml. Women with anti-D should not be issued with an antibody card documenting the finding of anti-D until it is conclusively established that the anti-D is immune. Pregnant women with immune anti-D. Anti-D concentration. Predicted clinical outcome. Less than 4 IU/ml. HDFN unlikely, continue to monitor. 4 to 15 IU/ml. Moderate risk of HDFN, requiring referral to a fetal medicine specialist. More than 15 IU/ml. High risk of HDFN requiring urgent referral to a fetal medicine specialist. Pregnant women with immune anti-C. Anti-C concentration. Predicted clinical outcome. Less than 7.5 IU/ml. HDFN unlikely, continue to monitor. 7.5 to 20 IU/ml. Moderate risk of HDFN, requiring referral to a fetal medicine specialist. More than 20 IU/ml. High risk of HDFN requiring urgent referral to a fetal medicine specialist. Recommendations. Samples from pregnant women with immune anti-D or anti-C should be assessed serologically at 4 weekly intervals to 28 weeks gestation and at fortnightly intervals thereafter, until delivery. Such cases should be referred to a fetal medicine specialist if the antibody reaches the critical level and/or the level is rising significantly, where assessment of the need for further monitoring will be made. Grade 1B. Pregnant women with immune anti-K or other KEL blood group system antibodies. Pregnant women with anti-K or other KEL system antibodies should be referred to a fetal medicine specialist when the antibody is first identified. If the fetus is known or assumed to be at risk, based on biological father or fetal typing, serological assessment at monthly intervals to 28 weeks gestation and at fortnightly intervals thereafter is required. Grade 1B. Recommendation. In all cases where serial Doppler assessment of fetal middle cerebral artery peak systolic velocity, MCAPSV, is being performed and antibody levels are in the high-risk range, ongoing assessment of antibody strength is unlikely to be of value and can be discontinued at the discretion of a fetal medicine specialist. Grade 1C. Recommendation. All women who have had an IUT in a previous pregnancy, for alloimmunization, should be alerted to the invasive fetal therapy service in any subsequent at-risk pregnancy to facilitate workload planning. Grade 1D. Recommendation. Where possible, scheduled MCAPSV monitoring is best performed at the beginning of the week to facilitate optimal access to the invasive fetal therapy service for IUT, when required, and availability of appropriate blood products. Grade 2D. Pregnant women with other red cell antibodies. It is only IgG antibodies that can enter the fetal circulation, and red cell antibodies with a significant IgG component are detectable by IAT. Cold reactive, IgM and low affinity antibodies to high prevalence antigens, e.g. CR1-related antibodies, have not been implicated in HDFN. Recommendation. Clinically significant antibodies, other than anti-D, C or K, should be excluded or, if present, assessed by titration, at the booking appointment and at 28 weeks gestation. If deemed necessary based on a high titer, 32 or greater, and/or a history of HDFN, referral to a specialist in fetal medicine should be made for further assessment. Grade 1C. Reports of laboratory investigations. Recommendation. In addition to blood group and specificity of any red cell alloantibodies present, reports must inform the clinician responsible for the pregnant woman's antenatal care of the likely significance of the antibodies, with respect to both the development of HDFN and transfusion problems. 1. Grade 1B. Recommendation. Pregnant women with clinically significant red cell antibodies should be given verbal and written information with details of each antibody specificity and its potential for causing HDFN and delay in providing compatible blood, grade 1D. Requirements for blood. Blood or blood components for the woman. Recommendation. For women with multiple antibodies or antibodies against high-prevalence antigens, an assessment of the likelihood of maternal need for blood, and discussion of appropriate measures to reduce the likelihood of transfusion, including correction of any hematinic deficiency, should take place as early in pregnancy as feasible between the maternity and hematology staff, grade 1C. Recommendation. Multidisciplinary planning of delivery should take place to reduce blood loss, and intraoperative cell salvage should be available where appropriate. This ensures optimal use of rare blood, taking account of the needs of the patient and the scarcity of the blood. Clear communication is required between teams within a hospital, and between hospitals if cases are referred to tertiary centers, to ensure appropriate management of transfusion in the mother and the baby, grade 1D. Blood for intrauterine transfusion neonatal exchange. Recommendation. For IUT or neonatal exchange transfusion, if maternal antibodies other than anti-D, C, E or K are present, advance warning of at least 24H should be given where possible to ensure that blood of suitable specification and negative for all relevant antigens is available. Grade 1D. Blood for neonatal small volume, top-up, transfusion. Recommendation. Clinicians considering transfusion in a neonate must check if the baby has had an IUT, as if so, blood must be irradiated to prevent transfusion-associated graft versus host disease. Grade 1A. Recommendation. In view of the less restrictive shelf life of blood for top-up transfusion, blood compatible with maternal antibodies other than anti-D, C, E or K, may be more readily available than blood for exchange or IUT, but advance warning should still be given to transfusion laboratories whenever possible. Grade 1D. What blood or blood components can be administered in the emergency situation to the mother known to have red cell antibodies? Recommendation. Obstetric, hematology and transfusion laboratory staff should discuss when to give alternative blood, when sufficient compatible blood is not readily available, based on the balance of clinical risks, severe hemorrhage versus a hemolytic transfusion reaction with potential associated complications, including renal failure, grade 1C. Recommendation. If ABO-D and K compatible blood that is not matched for other antibodies is used for resuscitation in the event of life-threatening hemorrhage, consider giving intravenous methylprednisolone 1g plus or minus intravenous, 4, immunoglobulin 1g kg preemptively. Grade 1C. Action at time of birth. D-typing of cord samples from D-negative women with no immune anti-D. Recommendation. All babies born to women who have clinically significant antibodies should be closely observed for evidence of HDFN. A DAT should be performed on a cord blood sample and hemoglobin and bilirubin concentrations should be measured, grade 1C. Pre- and post-delivery testing of maternal samples. Recommendation. D-negative women with no immune anti-D should have an initial FMH test at delivery and follow-up testing if required, in accordance with BSH guidelines for estimation of FMH. Grade 1B. Obstetric considerations. Short and long-term consequences. The presence of red cell antibodies does not pose a long-term health risk for the woman, but an antibody card should be carried in the event transfusion is required. Owing to passively acquired maternal antibodies, some infants may remain anemic for a few weeks following birth. Some infants will experience delayed anemia. Risk factors for this are anti-C antibodies and multiple IUTs. The incidence of severe developmental delay in children treated with IUT is comparable to the general population, 3.1 v 2.3%. Severe hydrops, a consequence of not treating in utero fetal anemia with IUT, is independently associated with neurodevelopmental impairment. Thank you.